Assalamu alaikum again. This is part two of principle and basic technique of endoscopic Indonesian approach. And we stopped in the last presentation in this image where how you handle the scope. Now, handling the scope is important because the nasal cavity can be divided to four compartments. As you can see here, one, two, is the upper part of the nasal cavity, and 3, 4 is the lower part. You can create a fifth part. We're going to show that later, depends on the procedure that you wanted to do. The first part or first compartment is visualization compartment where the endoscope going to be placed, and the lower compartment is the dissection section is number 3 compartment where sorry, number 2 compartment, the lower right nasal cavity typically, and number 4 is the dissector. Number 3 is left for extra instrument. Some people put nasogastric tube in the fourth compartment as a accessory section, especially at the beginning of the procedure, and then later it's removed and used for microdissector. As you can see here, the main surgeon is typically handling the lower compartment where the surgeon 2 will deal with the upper compartment, especially the endoscopic and visualization compartments. You want to create a space where between the compartment 1 and 2. That is to allow more space and more working space when you are inside, so the instrument won't fight each other. You will not hit each other with the instrument inside, as these instruments are long and the angulation will make them hit each other inside. So you want the scope to be pushed against the nostril edge superiorly, and the suction compartment will be pushed down, so that allows more space and more working space. This is how the compartment shown in the coronal axial rather view. The pathology need to be studied very well in image, all kind of image. Typically we ask for CT, CTA, or CT sinus, as well as MRI. Very rarely we need an angiogram if we're worried about bleeding and hypervascularity of the pathology. But you need to understand the location, exact origin of the tumor, the extension of the tumor, the type of the tumor is important, the consistency of the tumor. And based on the extension, you can divide the complexity level of endoscopic Indonesian approach to 5 levels. The first level is the sinonasal procedure, where you start to understand the basics of endoscopic Indonesian approach, especially for the neurosurgeon and neurosurgery resident. I always advise them to go and observe how our colleague and rhinologist do this procedure, and try to understand the small tricks and tips that need to be learned during these simple approaches. The pituitary tumor resection, as well as say cephalic procedure, can be done by one surgeon, but we usually like to work as a team. And the reason for that is we are trying to build up a team. We try to have 4 hands, 4 eyes, and 1 heart, one working team that understand each other. So when it comes to more complex and advanced approaches, that we know each other and we know how to handle things smoothly. Doing advanced procedure require extreme understanding of nasal anatomy techniques, as well as the type of pathology and extension in terms of neuroimaging, and that considered to be an expert level. You need to do lots of procedures and work many hours in the lab before you do this kind of approaches. The master level is very few centers that can deal with that. It's a lateral approach through the nasal cavity, and that is a little bit hard. We'll discuss it in further details during the course, of course. The extension, we mentioned that this is a picture from Labib Qassam that was published 2014. As you can see here, the midline or sagittal approach is relatively easier approach, especially if you're going to go to the sphenoid sinus. But as you go lateral, you're going to deal with arteries, in particular internal carotid artery, and branches from the vertebrobasilar system, as well as dealing with cranial nerves, in particular optic, third cranial nerve, sixth cranial nerve, 12th nerve, as well as anterior cerebral artery, superior cerebellar artery, ICA, anterior inferior cerebellar artery, as well as the pica. And we talked about this. This is lateral approach that is a coronal model that was published by mini group, but it's really a difficult approach, and you need to master the anatomy, and you need to be or having good team to be able to do these approaches. Consistency we talked about. Of course, we always say exposure, 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 but sometimes wide exposure is not necessarily if the consistency of the lesion is not hard and the lesion is suckable. Then you can do a relatively limited approach to remove the tumor. We need to use navigation. We always do Doppler ultrasound to identify internal carotid artery and other arteries. Neurophysiology is option, especially when you work around the brainstem and transclival approaches. CTA or CT sinus is important, MRI, and we use fusion image and sometimes intraoperative image in terms of CT scan, CTA, or even MRI, where it's available in our institute. Now, reconstruction can be easy or complex, depends on the pathology and the defect that was created, but the best reconstruction is one multi-layer reconstruction with graft and flap, and vascularized flap is the best and showed that it decreased the complication rate significantly in terms of CSF leak or delayed nasal complication. There are three sources, it says here too, but actually there's three sources of morbidities in these procedure. One is vascular, two is cranial nerves, three is pituitary and hypothalamus. Of course, the brain as well, but that considered to be part of the pituitary hypothalamus complication. The vascular complication can be venous, in particular to the cavernous sinus and surrounding or communicating other sinuses. That can be dealt with relatively easy compared to arterial bleed. Arterial bleed in terms of internal carotid artery, very difficult to control, but we have separate presentation for that. Generally speaking, it can be controlled if it's dealt with smoothly, but patient can lose lots of blood. Perforators is easily controlled, but has a significant sequela clinically, postoperatively, where you can have an injury to deep structure of the brain or brainstem, and that can create a significant problem for the patient. Of course, cranial nerve can be a problems, and pituitary profile need to be evaluated before, during, and after the procedure. I'm going to stop here and thank you very much.